All right, so this case is of a 33 years old lady. She is currently having a KPS of 70 or 80 perhaps. She first presented with seizures in back in 2021, and then at that time she had a non-enhancing right frontal lesion. She had a craniectomy and maximum safe resection in AKUH in September 2022. There was no residual disease, so she was kept on follow-up. Histopath was astrocytoma IDS mutant grade 2. And she remained stable on this for about a year and a half. In October 2023 में तक उनका stable scan था. But then she had seizures again in May 2024. And at that time, that's about 1.5 years from the index surgery. At that time, the MRI showed increased flare and T2 signals along the resection cavity, but still there was no new enhancing disease. Just
उधर नहीं आ रहा बेटा, उधर लोग मुझे नसर। आई
in
थिंक वी
this.
लॉस्ट यू। नसर, बीच में आपकी आवाज डिस्कनेक्ट हो गई थी।
हेलो, अभी आ रही है?
जी आ रही है, आ रही
अच्छा,
है। ये मई
so उनको
2024 वाली एमआरआई से आप ऑनवर्ड स्टार्ट प्लीज।
ओके, सो मई 2024 में सीजर्स के साथ प्रेजेंट हुई और उस वक्त जो एमआरआई था उसमें इंक्रीज्ड फ्लेयर और टी2 सिग्नल्स आए हैं। कोई इनहांसिंग डिजीज नहीं थी, देयर वाज जस्ट दिस इंक्रीज इन टी2 सिग्नल्स अराउंड along the resection cavity. So based on that, it was considered as disease progression, and she was subjected to radiation treatment. And she finished her radiations 5400 centigrades in September 2024, and after which she was
नसर, आई थिंक अगेन वी लॉस्ट यू सर।
where it could be radiation necrosis, but then perfusion scan showed that this was in fact progression. So then she underwent a craniectomy again this October, redo craniectomy and maximum safe resection. Once again in the MRI, there is gross total resection of the enhancing disease, and the histopathology is still the same, astrocytoma IDS mutant grade 2. This was the first scan before the first surgery. You can see the non-enhancing disease in the right frontal, superior middle frontal gyrus. Next.
अच्छा नसर, हमारे साथ ना डॉक्टर शायान एंड डॉक्टर शुमाइला आर विद अस, सो
Okay, all right, perfect, perfect.
हम उनका व्यू ले लेंगे। डॉक्टर
Please, please,
शुमाइला,
please.
प्लीज मैम।
Ji, Assalamu alaikum. So this is the first slide. I think it is from 2022 July. So we can appreciate that we are provided with three sequences. The first one is T2 weighted axial. The second is flare coronal, and the third is sagittal post contrast even weighted image. So on the first image, we can appreciate that there is an area of vasogenic edema because the cortex is paired and all the edema is lying in the white matter. And on flare, we can see the redemonstration of the same area. There is some element of T2 flare mismatch because the areas which are T2 hyperintense, some of them are low on flare, which goes in favor of IDH mutant astrocytomas. We cannot appreciate much enhancement in this, but the findings are in favor of the way there is vasogenic edema, and it appears that there is some neoplastic lesion. So I would call this a low-grade astrocytoma. Most likely, it does not look like an area of demyelination. It does not look like an infective etiology. It does not look like an infarct as the cortex is paired. So my first differential is a low-grade astrocytoma, and keeping in mind the T2 flare mismatch, I will consider IDH mutant lesions in this case. So the next is the next image which I'm provided is from October 2023. I think these are the post-operative images. We have इसमें एक T2 भी आपके पास पीछे था. So on T2 weighted images, we can see that there is resection. A part of the lesion shows resection. There are post-operative changes. Some area of T2 hyperintensity is still visible, but the mass shows surgical resection. On in the next slide, from the same time, October 2023, we can see that on flare there is Part of the lesion shows resection. There is some area of vasogenic edema still left around the lesion, which is flare hyperintense, but there is, resection of the lesion is also visible. No other abnormal area is identified. Some ex vicu dilatation of ipsilateral frontal horn of right lateral ventricle due to resection of mass and volume loss, and some area of gliosis as well, and capsulation gliosis in the surgical bed. That's all I can appreciate. So if we look at this new scan from June 2024, to me, although we don't have the images side by side, but if you just, make a mind or take a picture from the previous scan, to me, there is some increase in the flare edema surrounding the lesion. In the scan from October 2023, the edema was not reaching up to the Fox on midline, but in the new lesion, there is some increase in the size of edema, especially the third image in the first row and the first image in the second row. So to me, there is some progression in this lesion because the edema and the increase in bulk of the medial most gyrus adjacent to Fox on the right side. It shows a relative increase as compared to October 2023. आप अब पीछे भी करके देख सकते हैं इसको एक दफा इन्हीं एरियाज को. So you can see that there was the gyrus was not that bulky the way it is in the current images. Now go back to the next slide from 2024. So you will be able to, I'm sure everybody will be able to appreciate that. So this is the same June 2024 T2 weighted axial images. And I can appreciate the same thing that adjacent to the resected area, there is interval increase in the size and bulk of adjacent gyrus, best seen in the first image, appreciated in rest of the images as well. So to me, there is progression in the disease process. So then we have the post-contrast T1 weighted images from the same date, June 2024. And on sagittal, I can see that there are areas of patchy enhancement, although this type of enhancement was not at all present in the initial images when the patient, which were the first pre-op images. Only from that set we have the post-contrast. So to me, there is interval development of some patchy areas of enhancement as well. और ये primary behavior of lesion set is a little different from the primary behavior. So in between these two, the patient had radiotherapy.
Yes, he did
I
have
think yes.
radiation.
Yes, he did have
Okay.
radiation and chemo as well.
So the lesions, the scans which were seen previously from June 2024, after that the patient underwent radiotherapy, and as mentioned on the slide, that it ended in September 2024. So so I can see that there is some area of internal necrosis, probably secondary to post radiotherapy changes, which appear as flare, relatively hypointense areas. There is some surrounding vasogenic edema, but I can see that the inferior aspect of vasogenic edema is showing extension along the ventricle. Initially, it was ending just above the ventricular limit, but now I can see it in the paraventricular space. So I would like to see the post-contrast images from this date. We have to decide that are these post-radiotherapy changes, or these are plain non-contrast even weighted images. And on post-contrast images, the central area, necrotic area is redemonstrated, but the enhancement pattern is, it's very nodular, especially in the first image, there are multifocal areas of enhancement. Plus, the adjacent leptomeninges show some kind of nodularity to me. I will not call this radiation necrosis on the basis of these images, but definitely we do need some, you might be having some supportive images, like, for example, you can take help from perfusion or you can take help from PET. But to me, on the basis of these baseline MR images, I will not call this radiation necrosis because it is a well-defined area. There is so much enhancement. The enhancement is extending in the adjacent leptomeninges as well, and there are few other nodules adjacent to this lesion which are visible in the first image.
Thank you, Dr. Shumaya.
I think this is from the same set of images, axial and sagittal T1 post contrast देखे हमने, and now these are axial T2 weighted images. तो इसमें भी जो है the edema shows extension, but जो सबसे ज़्यादा convincing है, the most convincing sequence is the post contrast sequence, which is pointing more towards. I believe that there is change in the grade of the lesion as well. It's no more a grade 2 lesion to me on the basis of enhancement characteristics.
Indeed, that's what the question is from my side, because when I did an awake and I did a complete resection intraoperative, she had seizures as well and some postictal weakness as well, but that improved. The grade the histopathology has come out to be similar to the first one, and this is what my concern was. I thought that it has progressed and to a high grade lesion, but it's not the histopathology doesn't support that evidence.
Assalamu alaikum, Dr. Shayan here.
Dr. Shayan.
Probably, yeah, I was going through the serial imaging, and probably the change in characteristics is because of these concurrent CRT, CCRT, like the patient underwent chemotherapy and the radiotherapy. That's why there was a change in the characteristic, the necrosis we are seeing because normally the IDH mutant tumors do not change their grade. This is the norm.
Okay, thank you, Dr. Shayan.
I would go for change in grade, looking at because I am practicing at an oncology center where we are dedicatedly looking at post-chemotherapy, post-cyber knife behavior of lesions, and I'm working there, for past, I think 7 years. So to me, I believe that there is a change in grade. मेरे ख्याल में अगर if you can get a review of histopathology, just to be on the safe side, so that you can help the patient in a better way.
Right. Dr. Mazhar, sir.
हाँ जी, अब ये कि इसका जो पैथोलॉजी आई वो तो ग्रेड 2 आई है, लेकिन मे बी जैसे उन्होंने कहा कि इसका प्रीव्यू एक बार फिर कर लें कि ग्रेड हाई हो गया। अगर ग्रेड हाई आया है तो आई थिंक चूंकि इस पेशेंट को 54 ग्रे रेडिएशन लग चुकी है और वो इतना लंबे गैप से नहीं लगी, आई थिंक इट वाज जस्ट गिवन लास्ट ईयर प्रॉब्ली। सो फर्दर रेडिएशन इज गोइंग टू be a problematic in this patient. I would say कि इसकी grading करा लें, और the only option we I think अगर वहाँ पे complete resection नहीं हुई और disease रह गई है, so the question would be to give her some different chemo. उसको PCV मिली थी, अब temozolomide वगैरह chemotherapy दे सकते हैं, और the stereotactic radiosurgery का भी सोचा जा सकता है, लेकिन वी आर नॉट श्योर कि हाउ मच ट्यूमर इज देयर, और वो वही एरिया जिसको 54 ग्रे मिल चुकी है। सो देयर आर, इफ वी गिव री रेडिएशन इन सच अ शॉर्ट इंटरवल, there would be chances of a brain necrosis, which would be again problematic for her. So मेरे ख्याल में इसकी ग्रेडिंग करा लें, और अगर ग्रेड 2 भी आ गया कर, अब ये सर्जन और पैथोलॉजी में वो बताएंगे कि मार्जिन्स का क्या हाल है। अगर वहाँ पे रेजिडुअल डिजीज है तो शी वुड नीड प्रॉब्ली कीमोथेरेपी ही दी जा सकती है, और चूंकि 6 साइकिल्स पीसीवी के लग गए तो आई थिंक वन कैन ट्राई टीमोजोलोमाइड, और बाकी भी किसी से पूछ लीजिए कि उनका क्या राय होगी। मुनीब भी आई थिंक इज अवेलेबल।
Post of MRI is like gross total resection. Sorry, कौन बात कर रहा था? डॉक्टर फुजान, आप कुछ कहते हैं?
जी, मैं यही कह रहा था कि पोस्ट ऑफ एमआरआई के अंदर तो पूरी कॉन्ट्रास्टेक्टमी हो चुकी है इसकी, तो इनफैक्ट मैंने थोड़ा सा साइड का एडीमा भी थोड़ा सा उसका निकाला, लेकिन आई मीन इट वाज नियर दैट मोटर कॉर्टेक्स, और वो जो है पूरा I mean, she started developing some weakness. तो हमें, इनफैक्ट मैंने उसके बावजूद भी
हाँ
पूरा tumor निकाला और छोड़ना मुनासिब नहीं समझा।
ठीक
हाँ,
ठीक
बस आई थिंक
डॉक्टर
इन दिस केस अगर ये इसकी पैथोलॉजी रिव्यू हो जाए और ग्रेड 3 तक चला गया हो ये, तो फिर तो आई थिंक इसको कीमो लगनी चाहिए। रेडिएशन इज नॉट सेफ, री
तो वो
रेडिएशन।
उसका क्या, कौन सा मॉलिक्यूलर मार्कर कौन सा कराएं, CDK N2B कराएं, क्या कराएं?
तो वो आप पैथोलॉजिस्ट से पूछ लीजिए कि वो क्या कहते हैं इसको, अगर किसी ग्रेड मतलब एक बार जो भी उसमें पता चल सके कि अगर ग्रेड बढ़ गया, जिस तरह हमारी रेडियोलॉजिस्ट बता रही थी कि एक रेडियोलॉजिस्ट तो वो कहती थी कि नॉर्मली ग्रेड चेंज नहीं होता है, लेकिन अगर इसमें ग्रेड चेंज हो गया तो देन इट विल बी सेफ इफ शी इज यंग एंड फिट टू गिव हर कीमोथेरेपी रादर देन रेडिएशन।
we have Dr.
या
Muneeb also with us. We can ask
हाँ,
his
मुनीब से
opinion.
पूछ रहे हैं, व्हाट डज मुनीब से?
Uh, Thank you. Challenging case है, because I think as Dr. Mazhar said that radiation was done last year, so it's quite difficult. As it mentioned कि कोई residual disease नहीं है, तो SRS is not an option, radio surgery, because radio surgery is for those patients like we see some sort of cross disease in the recurrent setting ना, तो उसको हम target small area को mark करके करते हैं। अब complete resection हो चुकी है और अगेन इसको फ्रैक्शनेटेड रेडिएशन का हम सोच सकते हैं, लेकिन अगेन अभी डिजीज है नहीं।
हाँ नहीं, वो आई थिंक
कोई
दैट
राइट एंड
रेडिएशन
रॉन्ग
शुड
आंसर नहीं
बी
है
लेफ्ट
इसका।
अगेन।
मेरा ख्याल ये है कि इसको अगर कंप्लीट रिसेक्शन हो गई है, अगर प्रीवियसली पीसीवी मिली है, एक तो एक ग्रेडिंग हम उसको दोबारा चेक करा लें। जैसे डॉक्टर फौजान मेंशन CDK2N जो मार्कर है, तो अगर वो उसका चेक करवा रहा है, आई डोंट नो पाकिस्तान में अभी होता है, यहाँ पे नहीं होता, तो
नहीं, शौकत
बिकॉज
खानम में हो रहा है, शौकत खानम में है
हो रहा है। अच्छा,
CDKN।
ठीक है, आई एम स्टिल लर्निंग। तो ठीक है, तो इसको क्योंकि ऐसे अगर ये चीज पॉजिटिव आ जाती है तो दो ट्यूमर बिहेव लाइक ग्रेड 4, क्योंकि ये जिस तरह की हिस्ट्री आप बता रहे हैं, लो ग्रेड ग्लायोमा की तरह बिहेव नहीं कर रही डिजीज ये।
हाँ,
अगर
इसीलिए
किसी
मैं
की
कह रहा था कि
ट्रीटमेंट मिल चुकी है। हाँ,
हाँ, तो अगर ग्रेड बढ़ गया तो आई थिंक कीमो एडजुवेंट टीमोजोलामाइड इसको नहीं दी गई, वो दी जा सकती है इस स्टेज के ऊपर। अगर इनका ग्रेड भी वही दोबारा से ग्रेड 2 आया तो जस्ट ऑब्जर्व हर, डोंट गिव हर एनीथिंग एंड जस्ट फॉलो हर अप। अगर ग्रेड बढ़ गया तो ओरल कीमोथेरेपी स्टार्ट कर दें। रेडिएशन वुड नॉट बी सेफ इन हर केस बिकॉज दैट वुड ऐड टू
रेडिएशन देने से,
कॉम्प्लिकेशंस।
हाँ एटलीस्ट मेरा ख्याल ये हम ये कंसिडर उस टाइम कर सकते हैं, अगर हम प्रीवियसली रेडिएशन की जो OR कंस्ट्रेंट उसको देख लें। यूजुअली फिर ये कि अगर एक साल के से ज्यादा गैप आ गया है, तो सम केसेस में हम फ्रैक्शनेटेड स्मॉल एरिया को जस्ट जो रिसेक्शन कैविटी स्मॉल, उसको 35 and 10 हम कर सकते हैं, लेकिन अगेन वी हैव टू डिस्कस।
और डॉक्टर
हाँ,
इट्स
मजहर,
नॉट
जब हम उसी कीमोथेरेपी की बात कर रहे हैं, सो यू आर सजेस्टिंग कि वी हैव टू शिफ्ट टू टीमोजोलामाइड बिकॉज
अगर अगर इसका ग्रेड 3 या 4 हो गया,
है।
अगर वो
राइट राइट
एक्सटेंसिवली उसकी
राइट
स्कैनिंग करके देख लें, फिर तो टीमोजोलामाइड ही देना जरूरी होगा, क्योंकि हाई ग्रेड में टीमोजोलामाइड काम करती है। और अगर ग्रेड 2 ही आ गया दोबारा तो आई थिंक शी शुड बी फॉलोड अप।
राइट ठीक
डॉक्टर
ठीक
डॉक्टर
आसिम।
हसन, आई थिंक इसमें हमें परफ्यूजन या स्पेक्ट्रो की थोड़ी हम हेल्प ले सकते हैं, या फिर नेक्स्ट फॉलोअप तक, बाय द टाइम वी आर गेटिंग अ रिव्यू ऑफ हिस्टोपैथ, we can take help from perfusion imaging. And somebody is asking from the audience as well that what were the perfusion findings. So I believe that perfusion was not done, so radiation
No, no,
necrosis.
perfusion was done before the
परफ्यूजन तो हुआ है ना।
second operation. उसके
हाँ
अंदर perfusion was high, and perfusion said that it's a tumor, it's not radiation
Okay,
necrosis.
okay, okay.
हाँ
So
हाँ,
I
अभी
will
तो
note
परफ्यूजन की
that.
जरूरत नहीं है।
राइट
ठीक ठीक।
एंड डॉक्टर शुमाइला, आपका पोस्ट ऑप स्कैन के बारे में क्या ख्याल है, अकॉर्डिंग टू
देखिए,
यू,
जो
लाइक?
पोस्ट ऑफ स्कैन है ना, देयर इज आई मीन द सेंट्रल एरिया व्हिच वाज नेक्रोटिक एरिया, वो तो डिकम्प्रेस हो गया है, बट देयर इज स्टिल सराउंडिंग irregular nodularity, especially appreciated on the images which are currently displayed. So
Nasser,
Is it
I would
possible
I
that I
would I
could
would
share
request
the
Nasser to just share the MRI, post op MRI जो ओरिजिनल उसके हैं वो, क्योंकि उसके अंदर T1
I have it,
नहीं
I have
भेजा इसने, T1 विदाउट कंट्रास्ट, सो वो T1 के साथ अगर देख लें तो आई थिंक दैट विल बी मोर क्लियर।
सर आप मुझे स्क्रीन शेयर करने दें, आई हैव द स्कैन्स रेडी।
जी बस।
Can you see the screen now?
Yes.
And so I'm gonna scroll. On the left is T1 plane, on the right is T1 post contrast. I'm gonna scroll, and then you can stop me wherever you want to. So the T1 is not volume, but T1 with contrast is volumes.
So I think if you can stop here, there is a central area which is hemorrhagic, right? But the peripheral area which is not enhancing is showing nodular enhancement. I'm sure I'm able to explain what I'm trying to say. सबको नजर आ रहा है ये. The enhancement is at the area which is hypointense on T1, right? Did we have any perfusion on these post-op images?
Not on these post-op images, ma'am.
Okay. So I think a short-term follow-up is going to be really helpful because you have a good baseline post-op image, and you don't have to start an treatment instantly because you will wait in any case for a rehistopath. In the meanwhile, in 3 to 4 weeks, this was done on 25th of October. So if we get a short-term follow-up in 4 to 6 weeks and look at the behavior of the lesion by comparing these images, एनहांसमेंट तो खैर है कुछ ना कुछ और है भी कुछ नॉड्यूलर सी काफी हद तक रिसेक्शन भी हुई है डीकम्प्रेशन तो अच्छी हो गई है लेकिन जो सेंट्रल इवन हाइपर इंटेंसिटी है अराउंड दैट आई कैन सी सम एनहांसमेंट स्टिल someone is
Actually,
asking
इसकी
about the DWI images in the chat. So I believe when there are hemorrhagic products, the false diffusion due to the hemorrhagic products in post-op period, they are quite deceiving.
मेरा कंसर्न ये है कि इसकी रिकरेंस इतनी जल्दी हो गई आफ्टर रेडिएशन एंड सर्जरी कि मुझे लगता है कि इसका ग्रेड बढ़ गया हो गया या जो भी है क्योंकि नॉर्मली ग्रेड 2 में आफ्टर 54 ग्रे विद इन ईयर ट्यूमर रिकर नहीं होता है इतना मतलब इट गोज ऑन फॉर स्टेबल लीजन फॉर क्वाइट अ वाइल इवन अगर वहाँ रेजिडुअल डिजीज भी हो 1 साल के अंदर सो यही इंपॉर्टेंट चीज आई थिंक पैथोलॉजी एट दिस स्टेज
ठीक सो आई थिंक सो द डिस्कशन जो मुझे समझ में आई है हमारी ये है कि वी हैव टू have him like short follow-up, repeat the grading. If there is any change in grade, then we go to the temozolomide. If there is no change in the grade, we going to have follow-ups,
follow up
right?
yeah
So I just want to add, yeah,
Dr. Asim, sir,
yeah,
yes.
yeah. So the important thing is that recurrent cases is always challenging, whether it is a grade 2 or grade higher grade. The challenges, particularly in this case, is that if we look at the scan, the tumor began with the flare changes. There is no contrast enhancement initially. But subsequently, the scan that was done last year that show actually progression has some contrast enhancement, patchy contrast enhancement as well. And the most recent scan that was done this year before surgery has a conspicuous contrast enhancement. But remember, one thing is that there is also flare changes as well because this tumor began with. So it is difficult to say whether there is a complete excision of the tumor or not because of the infiltrative nature of the thing. Dr. Fauzan has very beautifully explained all the things and the thing, but because of the nature of the disease itself is very difficult to predict. That's why it is very difficult to say about what is whether it is characterized as a there is a remaining residual disease over there or not because of the nature of the disease. The second
Yeah.
thing would be the second thing would be is actually the role of further treatment management. Radiation therapy, because this patient got radiation therapy last year in September completed, and within a year it has progressed. So giving back and offering radiation again, how would it actually behave? It is difficult to say. We don't know whether when the last time when this patient has this progression, if we consider any biopsy at that particular in time, that might be because the radiation doses that has been prescribed in this particular is 54 gray. For you, that is usually recommended for the low grade glioma patients. For high grade, you have to give a little bit more radiation therapy in particular scenario. But definitely, this patient receive all this perspective or all this treatment modality in a standardized way. So the next step would be, I will agree with the panelists that this patient require actually relook actually the pathology report, because it is very crucial in this particular case, because if it is, because all the radiological features and all the discussion even by the surgeons and our radiology colleague is suggesting of that the tumor has progressed in terms of the radiological behavior or characteristics, so that predict the nature of the disease, that was more on the higher side of the glioma, rather than, despite the fact that we have this IDH mutant intact. But as mentioned someone, that there is also CDK on these CDKN2A and CDKN2A and 2B mutation. If it is possible, then one can get this thing in pipeline. And I would more incline toward start some systemic treatment because because all the discussion even in the post of MRI suggests that there is, it is very difficult to say whether it is triggered or the post-operative changes or the pre MRI changes, the pre treatment changes were there. So I would more inclined toward start at least with some systemic treatment, keep this patient on follow-up, get a response MRI, and then see. Then at that time, one can actually discuss about the role of further radiation therapy, because the one thing is that the term duration is small. In this particular case, is 1 year, but the important thing is that even in 1 year, the tumor progresses after getting radiation therapy. That is something very difficult to say. The tumor that progresses or after getting radiation therapy and you're offering again radiation therapy is definitely how you would actually behave. There's a role of both the fractionated radiation therapy on this or the RTOG trial and the other than the as well as the STO tactic. But the important thing is that because we are dealing with a tumor that is infiltrating, if somewhere the question arises regarding the radiation therapy, I would more inclined toward the conventional one rather than the STO tactic. Thank you.
Thank you, Dr. Asim. Thank you so much.
Thank you. All right. So let's move to the next case. So this is from my hospital. I saw this gentleman in my clinic. Dr. Yamna, can you please unmute yourself and present?
Good morning. I'm Dr. Yamna. I'd like to present the case of a 62 years old male with a pertinent history of diabetes mellitus and hepatitis C related chronic liver disease and multifocal hepatocellular carcinoma. He presented to us with a 6-month history of progressive left-sided headache and painful ophthalmoplegia associated with diplopia, left-sided ptosis, vomiting, and an unintentional weight loss of 26 pounds. He's a non-smoker and does not consume alcohol, but he's got a very strong family history of hepatocellular carcinoma, with his father affected and his brother having undergone a liver transplant. His examination revealed a left pupil-sparing third nerve palsy and a sixth nerve palsy. Can we move to the next slide? His imaging studies of the abdomen revealed a cirrhotic liver with hypertrophy of the left lateral and caudate lobes, and more than 15 variable-sized hypodense lesions in the both lobes, the largest measuring 37 millimeters in segment 3 and 27 in segment 5. As you can see, these lesions showed an arterial enhancement with venous and delayed phase washouts. These findings were consistent with hepatocellular carcinoma. There was no biopsy done. He underwent days in transarterial chemoembolization in February, and currently he's on lenvatinib and tenofovir. We ordered his MRI brain and orbits that Dr. Okay. We ordered his MRI brain and orbits that demonstrated an ill-defined lesion involving left pituitary, sphenoid sinus, and cavernous sinus, along with encasement of the left internal carotid artery. The lesion measured 33 millimeters anteroposteriorly, 20 millimeters transversely, and 27 millimeter craniocaudally. He is a pre-op patient, and currently we are planning to go with an endoscopic transsphenoidal resection of the pituitary or cellular lesion.
So yeah, thank you, Dr. Yamna. So our question to the board was, since we are suspecting it's a metastatic lesion, but we are not sure, right? So should we get the liver biopsy first? Because that's what the MRI has shown, but we are not yet sure. But I think I will jump to these images. I'm sorry, we just received बाहर से हुए थे scans and then took pictures from my mobile. Dr. Shumaila, can you please give your insight on this imaging?
Thank you very much, Dr. Hassan. Yes, I agree the images are too small, and digging through them was really very difficult. But when I tried to look at especially the coronal and the sagittal images, if you can magnify the
Right.
sagittal images seen here on your screen. So what I could see was that there was some extension of these signals in the sphenoid sinus and in the clivus. And these are predominantly hypointense on T2 weighted images. So they have a very smooth kind of appearance. And although encasing ICA, but to me, this is something lying more in the sphenoid sinus and extending towards the clivus.
Right.
I'm not very sure that these are Mets or not, and I'm not sure there is extension in cavernous sinus, but the epicenter is not in cavernous sinus.
Right.
So I think getting a CT scan in this case is going to be really helpful. ये जहाँ आपका ये कर्सर है इस वक्त इसी सेजिटल पे आप आ जाइए साथ और यहाँ पे if you look at the clivus, so you can see that there is extension. इसके साथ वाले को भी जरा drag करके लेके आए सेंटर में sagittal को the image just next to that.
Right. ये वाला आप कह रही थी डॉक्टर शुमाइला, this one? Or this one?
G, this one, both of these. So you can see that it is invading part of clivus, right? The tip of the clivus is intact, but if there are some signals which are showing extension in the clivus. और जब आप ये ऊपर वाले images coronal हैं, the images adjacent to this, the first row which is partly visible.
This one?
इसमें आप देखें, yes, the right sphenoid sinus show aeration, but the left sphenoid sinus is completely filled by these signals. So मेरे ख्याल में अगर आप इसके DICOM images, if you can get hold of that and you can share them properly through email, क्योंकि ये जिस जगह का scan हुआ हुआ है, they do have a PACS with them and they can probably, the patient can bring the CT for you. इसकी diffusion characteristics and plus a CT scan from this region. I think you will be able to delineate that in a better way.
Right. Okay. ठीक है. Dr. Asim, sir.
So there are multiple things. The first thing is that if it's possible to get in and remove the as much as possible of the lesion, then I would more incline towards that thing. The other thing is we got this patient SEC, but we don't have any biopsy previously. What about the alpha fetoprotein F here in this particular case? Was it traced initially or it was within the normal range? Any idea about that thing?
डॉक्टर यमुना, हमारे पास है अल्फा फीटोप्रोटीन का था.
Did we have? जी, जो हमारे पास इनके लेवल्स थे, फरवरी में they were 36.2, अप्रैल में they were 55.1, और जो लास्ट हमारे पास लेवल्स हैं they were of June and they were 106.4.
Okay.
September 19 पे जो लेवल्स थे they were 167.5.
अच्छा. Right.
Okay, so this patient need to be followed with medical oncologists regarding the management.
So the patient was referred to us. The patient was referred to us by the medical oncologist. So his opinion was. Yeah. You said.
So coming back to the point of discussion in this particular case is regarding this sphenoidal or the supracellular lesion. I would more incline towards getting a biopsy of that thing, and the debulking as much as possible, because it is difficult to say because the location is that and the characteristics all as described by Dr. Chamala is also something that is not very characteristics of the hepatocellular carcinoma. So it is better to have a biopsy, and then definitely this patient require actually depending upon the pathology report further treatment accordingly.
Yeah, because patient is symptomatic also, उसकी vision भी affect हो रही है. So ठीक है. Dr. Mazhar, sir, what are
हाँ
your
जी, आई
thoughts?
थिंक आई एग्री विद डॉक्टर आसिम. इसकी एक तो डिबल्किंग अगर हो जाए, अगर हो सकती है, हिस्टोलॉजी भी आ जाएगी, एंड देन वन कैन टेक द केस फर्दर अप बिकॉज ही सिम्टोमेटिक. तो अगर ये डिबल्किंग हो जाए और उसके बाद तो ही कैन डेफिनेटली बी गिवन रेडिएशन और समथिंग to relieve his symptoms. बाकी इसका अगर hepatocellular carcinoma है, that's also I think at this stage I'm not sure कि उसका surgically resectable है कि नहीं. लेकिन I think this thing is giving him more symptoms at this stage, so this should be debulked and then histology and then rediscuss.
ठीक, thank you.
What is the life expectancy of this patient?
So ये मेरा सवाल था oncologist से पहला. So according to him, he's more than 6 months. So I'm not sure कि exactly कितना है. So but Dr. Fawzan, आपने since you have unmuted yourself, I was planning of endoscopic transfenyl. What are your thoughts? क्योंकि नजर तो आ रहा है स्फेनॉइड में भी है और
जी आई थिंक डोएबल तो है, लेकिन कैवर्नस साइनस में थोड़ा सा वहां पे
हाँ
जाना
उसमें
थोड़ा सा
आप
मुश्किल
लेकिन
होगा.
कैरोटिड तक अगर आप कर लें तो अगर आप बल्क को देखें
वो डिबल्क
है
तो
ना.
हो जाएगा, वो
हाँ
उस पे ऑप्टिक chiasm पे प्रेशर थोड़ा सा
आई
हट
थिंक
जाएगा.
डॉक्टर महबूब भी हैं हमारे साथ, उनकी भी जल्दी से राय ले लेते हैं.
जी
डॉक्टर
जी.
महबूब जी सर.
I was
अस्सलाम
about to comment on this. This is I think more in the sphenoid sinus and into the clivus, so it is accessible endoscopic. So debulking through endoscope and a biopsy would be of help.
कल खराब थी लेकिन ठीक हो गई.
Thank you, sir. Dr. Munib, anything you want to add?
समझ
Dr.
जाएंगे.
Shayan, anything, please?
No, thank you. I totally agree with the panelist comments.
Right.
Thank you.
Thank you. Dr. Shayan, anything that you want to add? We can move to the next case.
No, nothing to add. I agree.
Okay,
Please
thank
move.
you. Okay, so let's get to this last case of today's session. Dr. Asim, who will present the case?
Dr. Hassan, you will get a CT in the previous case, right? Before you
Yes,
go
yes,
transfer
ma'am.
results.
That we will get the CT. That we
Yes,
have
yes.
that your recommendation. We'll get the CT. Oh, definitely.
Thank you. Thank you.
Thank you.
So Dr. Hassan, Dr. Kainat will present if she's present
Okay.
here. Otherwise, I can proceed.
Assalamu alaikum, Dr. Kainat.
So this is a case of a 67-year-old gentleman with KPS 100. He presented in ER with generalized tonic-clonic seizure and behavioral changes for 6 months. Next, please. His MRI brain with contrast was done in August 2025. Next, please. May I please request the radiologist to comment on the MRI?
Dr. Shayan.
Well, we are provided with T1 pre and post contrast images. In the first row, these are unenhanced, and in the second row, we have enhanced images. So these are homogeneously enhancing lobulated lesions in bifrontal lobe, which appear to be extraaxial, and these are attached to the forks and the meninges anteriorly, and they are showing surrounding basogenic edema, which appear hypo intense on T1 weighted images. They are also causing mass effect on the ventricles. Next slide, please. On T2, you see they are returning heterogeneous signals on T2, relatively isointense to gray matter. And you can see the surrounding vasogenic edema, which is more evident here on T2 weighted sequence. And they are causing mass effect on the ventricle. However, there is no hydrocephalus as such. Next image. So these are the sagittal, and you can see the extent of the tumor, how it is attached to the meninges and the forks. And it is also causing a lot of mass effect over the corpus callosum as well. And these are the coronal sequences on a flare sequence in which we can see that it's appearing relatively isointense and with surrounding edema. Next.
So this patient underwent neuronavigation guided bifrontal craniotomy and maximum safe resection of the lesion in August 25. Histopath was consistent with the atypical meningioma CNS WHO grade 2. His post-op MRI was done.
So on these images, in the first row, these are unenhanced, and the second row are the enhanced images in which we can see hemorrhage in the surgical bed, and we see enhancement around the resection cavity, which is marginal. We also see some enhancement around along the dura anteriorly in the bifrontal region. This may represent post-surgical changes. However, again, small residual cannot be excluded in these images, limited images. Can I have a look on the other slide? Again, we see a lot of hemorrhage and edema in the surgical bed. And there's some relief of mass effect. And on these images, again, we see there's marginal enhancement along the resection cavity. So again, small residue cannot be excluded on these limited images, but there's good resection of the tumor. Maximum safe resection has been performed. Over to you.
Okay. Right. Can we ask Dr. Shumaila also? If Dr. Shumaila, if you want to add, please.
No, I don't think so. There's anything to add. Yes, there was a large extraaxial bifrontal lesion with some vasogenic edema and mass effect on the underlying ventricles and brain parenchyma, and maximum resection is done. Only some dural tail, enhancing dural tails, and some peripheral enhancing tissue is visible. And post-surgical hemorrhage changes are also seen. So I don't think there is much to add. Thank you.
So, Dr. Asim, over to you, sir.
So this is basically a atypical meningioma, status post surgery with maximum safe resection. So actually the question to the tumor board.
आपकी आवाज बहुत वो आ रही है, distorted.
अब सही आ रही है? Is it better now, or is it still breaking? डॉक्टर एहसन, आवाज आ रही है अब सही?
अब आ रही है सर, जी सर.
Okay. So basically because it is a grade 2 meningioma with maximum safe resection. So my question regarding the further management from the tumor board, if Dr. Mazhar or Dr. Munib share his comments on this case.
Sir, Dr. Mazhar, sir. सर आप म्यूट हैं, डॉक्टर मजहर.
हाँ जी, आवाज
जी सर, अब आ रही. जी सर.
सेक्शन हो चुकी रेजिडुअल डिजीज देयर बड़ा था, तो अगर इसकी रेजिडुअल डिजीज है तो आई थिंक वन शुड रेडिएट दैट, और अदरवाइज अगर रेजिडुअल डिजीज के चांसेस कम है देन क्लोज फॉलो अप ही रखें.
थैंक यू. डॉक्टर मुनीब.
अच्छा, basically, sorry, I was on call in between, so I missed the comment by Dr. Mazhar. अच्छा, इसमें ये कि grade 2 atypical meningioma है, always debated. अगर complete resection हो गई है तो अभी भी इसमें डिबेट है कि whether adjuvant radiotherapy should be offered or not. I think अगर based on the patient performance status और अगर residual disease है और considering the large size of the disease और भी जितना रेडियोलॉजी ने कमेंट किया कि residual disease could not be ruled out, I would be more inclined toward adjuvant radiation.
हाँ, यही मैंने भी कहा है मुनीब कि आई थिंक एडजुवेंट रेडिएशन मिल जानी चाहिए। परफॉर्मेंस अच्छी है मरीज की, और बहुत बड़ा ट्यूमर था जो रिसेक्ट हो गया। टू प्रिवेंट रिकरेंस, आई मीन एट दिस स्टेज रेडिएशन कुड बी इफेक्टिव रादर देन लीविंग इट फॉर टू लॉन्ग, क्योंकि वो ये शक जाहिर कर रहे हैं कि कुछ डिजीज पीछे पड़ी हुई है।
बिल्कुल बिल्कुल, आई एग्री।
डॉक्टर आसिम।
Yeah, I
तो
totally agree
इसमें
with the both.
तो
Sorry.
इसमें मेरा क्वेश्चन ये है कि इसमें रेडिएशन यानी क्या होगी, होल आई मीन एसआरएस का कोई रोल है इसमें, या होल ब्रेन होगी या कैविटी होगी
नहीं नहीं, होल
रेडिएशन?
ब्रेन तो नहीं होगी, जस्ट द कैविटी, और जहाँ पे ट्यूबर था उस कैविटी को रेडिएट करेंगे। एसआरएस इसमें नहीं होगा, क्योंकि एसआरएस नॉर्मली हम लोग इस तरह सिचुएशन में नहीं देते दैट कैन डू मोर हार्म। आई थिंक कैविटी को रेडिएट कर देना चाहिए, जो अभी हमारे स्कैन्स में नजर आ रहा है, दैट वुड बी। और जो डोज होगी दैट वुड बी वही 54 ग्रेन इन 25 to 30 fractions, 180 centigrade पर डे, इस हिसाब से।
राइट, थैंक यू।
So coming back to this particulars, I totally agree with both the panelists, Dr. Mazhar and Dr. Munib, regarding the further management of this patient from the radiation perspective. Yes, data after some suggestion find a lot of literature they provide that support that even in the growth hormone resection, if you offer radiation therapy, it will provide a better local control as compared to the patient who just kept on follow-up. But there are multiple other factors that need to be incorporated in decision-making process rather than just focusing on the number one thing. But important thing is that in meningioma, surgery is the main modality. The point raised by Dr. Mazhar is very valid because the burden of disease is currently is very low, so the radiation is more effective. Once it is start to grow up and it is started to grow, then it is very the dose that is required for actually to control meningioma is pretty high. But that's why it is our limitation. We don't usually give a certain dose beyond a certain dose, so that will result in a poor local control. The third one that's behavior one meningioma that is slowly growing and takes years to actually progress inside. But at the other hand, it also has some features of grade 3, because in grade 3 meningioma, whatever the extent of resection, you need to offer radiation therapy to the patient in order to provide local control. So because we don't have such data right now to actually predict whether the grade 2 behave as a grade 1 or grade 3, though there's a lot of molecular marker, but its availability is challenge, and it is also on the experimental arm as well. So it is very difficult to totally agree with the plan with the offering radiation therapy. One of the factor that actually help is one is size and size of the tumor, the site of the tumor. If it is located at a site where the further surgical resection and in case of progression of disease is difficult, I would more inclined to offer radiation therapy. And the third one is the invasion, brain invasion. That is also because brain invasion itself is a one of the criteria of labeling meningioma as a grade 2. So that is also very important. Regarding the modality or the volume, I totally agree with the panelists that for meningioma, particularly in the post-op setting, usually the common method followed by majority of the institutes is actually the fractionated radiation therapy to the surgical resection cavity and along the meninges that has been actually involved by the tumor initially. The brain parenchyma is not as such at risk until unless it was involved by the tumor, but you have to take a little bit of parenchyma also within your target volume. Regarding the stereotactic radiation therapy, the role of stereotactic is emerging, particularly in the case of frequent meningioma who is already exposed to the radiation therapy previously, or if there is a small lesion. But in grade 1 meningioma, you find a lot of data regarding the stereotactic radiation therapy. Usually, it is more preferred approach in the grade 1 meningioma, depending upon the criteria that has been established by the society. But the other thing is that in atypical meningioma, it is usually in cases where the patient is already exposed to the radiation therapy and you are offering re-radiation and the lesion is small, then one can actually consider stereotactic radiation therapy. However, in the upfront setting, the usually preferred approach is the conventional one, as mentioned by our panelists. The third one is that because there is no as such randomized trial that actually address the role of radiation therapy in the cross-total setting. However, there is a one trial that is named Rome trial. I think the accrual has completed and it is in a couple of in a very shortly or in a couple of months it has been published. It will actually helpful in our decision making process how to proceed, because that is a randomized trial in which the patient were randomized between the patient who has a cross-total section of atypical meningioma offering radiation therapy versus close observation. So the result is awaited and let's see how it is what it actually tells us in our decision making process. Thank you.
Perfect. Thank you, Dr. Asim. That was an excellent insight and a lot of updates for me. Thank you very much. So the floor is open. We have a couple of minutes, I think. If anyone wants to ask any question to our panelists, please feel free to unmute, to text whatever you want. If we don't have any further question, then we will end the session.
Just a question about this last case. What about watchful waiting? Because patient is 67-year-old and KPS is quite good. So we regularly follow up with the MRI, and once we see if there is regrowth, because at this age, radiation might have certain effects.
So, very good question, Dr. Mahbub, regarding the role of observation. As I mentioned, there is no actually the level 1 data that actually supports or that actually differentiate between whether to offer radiation therapy, particularly in atypical meningioma. But there are certain limitations, as I mentioned previously in my discussion, that we don't have actually, it is very difficult to predict the behavior of the grade 2 meningioma. The other thing is that about the site of the tumor, because the location of the tumor, and the third one is actually the brain parenchyma invasion. So if the brain parenchyma are more inclined to it, is in this particular case, the other thing is that yes, we can give an option of close observation provided the patient understand or the family understand that in case if there is a tumor progression, then we need a surgical help first, because as mentioned earlier, radiation treatment has the limitation, because if we go with the conventional radiation therapy, then it is very difficult. As the burden of disease increases, the local control with the radiation therapy is start to actually decrease. So that is very important point. So targeting the area with the minimal bundle of disease has provided a better local control, because in a lot of retrospective study also compared this thing that if the patient who received upfront radiation therapy versus the preparation radiation got radiation therapy on progression, the patient who got radiation early has a better local control as compared to the patient who received radiation therapy on progression. So all these things, if we compare or consider all this point in the decision making process, then definitely I would more incline towards offering radiation therapy rather than just offering observation to this patient. But your point is well taken, that the observation is one of the option available in grade 2 meningioma, provided the patient understand. The patient compliance is also very important, and our surgical colleagues and the other part of the multidisciplinary members, team members also appreciate that in case of progression, we need to require us support from our surgical colleague as well. Thank you. I hope I answered the question. Thank you.
I think I remember once Dr. Mazhar mentioning about, this kind of dilemma came. अगर patient बात बिल्कुल समझता है and kind of we are hopeful and confident कि वो follow up रखेगा, so we can keep. But most of the time, I think Dr. Mazhar, you mentioned something like this कि हमारे पास patients आते हैं and then just we lost to follow up.
हाँ
So
जी, ऐसा ही होता है कि अगर पेशेंट इतना एजुकेटेड और या उनके रिसोर्सेज ना हो तो समटाइम यू लूज फॉलो अप पे, और फिर इफ द डिजीज कम बैक एंड दे कम लेट तो दैट एट दैट स्टेज इट्स डिफिकल्ट. तो अगर पेशेंट अंडरस्टैंड करता है और उसकी, और दूसरा इंपॉर्टेंट चीज़ है इसकी परफॉर्मेंस. इफ हिज परफॉर्मेंस इज नॉट ग्रेट एंड ही हैज अदर कोमॉर्बिड्स एंड यू, तो उसमें वन कैन फॉलो इट अप रादर देन. लेकिन अगर परफॉर्मेंस अच्छी है तो आई थिंक गिविंग रेडिएशन एट द रिकरेंस इट वुड बेटर टू गिव इट नाउ. इसमें डोज तो इतनी हाई नहीं है, 54 गए है और कैविटी भी छोटी अब रह गई है, डिजीज खत्म हो चुकी है, लेकिन अब अगेन पेशेंट के साथ डिस्कस करना चाहिए। आई डोंट थिंक इतने ज़्यादा साइड इफेक्ट्स आते हैं बिकॉज वी डोंट ट्रीट द होल ब्रेन, इट्स जस्ट अ कैविटी। और हमारे पेशेंट्स को तो हम 60 ग्रेड तक जिस तरह है ना एनाप्लास्टिक ब्रेन ट्यूमर्स भी दिया जाता है, या तो वो भी फॉलो अप पे ठीक रहते हैं। सो आई थिंक अगर परफॉर्मेंस अच्छी है एंड पेशेंट के साथ डिस्कस कर लिया जाए एंड इफ ही एग्रीज, क्योंकि रिकरेंस तो पे डिपेंड करता है। टिपिकल मेनिंजियोमा अगर कंप्लीटली रिसेक्ट नहीं, इट विल ग्रो डेफिनेटली।